Hello, my name is Vivek Reddy. I'm an electrophysiologist at Mount Sinai Medical Center. I'm the director of electrophysiology. What I'd like to do is to talk to you today a little bit about atrial fibrillation, what it is, and what are the options in terms of treatment. As you see here, the image on the left is a picture of the heart in normal regular rhythm. We also call it normal sinus rhythm. This is what the heart normally does. They're the top chambers, which you see here, called the atria, and the bottom chambers, called the ventricles. Normally, there's the normal pacemaker of the heart is situated in the top chambers. Once the top chambers contract and electrical impulses pass through, then the impulses travel to the bottom chamber, and then the ventricles, the main pumping chambers of the body, contract. That's the organization of the heart that allows the heart to pump blood throughout the body. Now that's normal. What happens during atrial fibrillation? The problem is in the top chambers. As you see from the image on the right side, the top two chambers, again called the atria, are beating in a chaotic fashion. There are electrical impulses traveling throughout these top chambers, and this chaotic activity results in what's called atrial fibrillation. This results in a couple of things. First, because the top chambers are beating erratically, they're not contracting in a synchronous fashion. They're not pushing blood into the bottom chambers as they should in a coordinated fashion. Number two, because the top chambers are beating so fast, that in turn causes the bottom chambers to beat very fast. And when the bottom chambers beat fast, that gives the feeling of palpitations, the feeling that the heart is racing, the feeling that sometimes one can't catch their breath. What happens when one has atrial fibrillation? Well, the most important problem is the possibility of stroke. When the heart is not beating properly and the top chambers are not beating properly, blood can stagnate. When blood stagnates, it can clot. And when clots occur, then those clots can dislodge, travel to the brain, and cause a stroke. So that's the most important problem with atrial fibrillation, and one of the most important aspects that we need to address. Beyond that, there are other things that atrial fibrillation has been associated with, including conditions such as dementia as one becomes older, and even premature mortality. The reasons for this are not completely clear, but we know that it's true. Now, what are the more acute problems with atrial fibrillation? Well, many people with atrial fibrillation have symptoms, and these symptoms can range from very mild symptoms to more extreme symptoms. And these extreme symptoms can be palpitations, again, the feeling that the heart is beating rapidly, the feeling of shortness of breath, that one can't catch their breath, and that may occur only with activity, or it may even occur at rest. Also, one can have chest pain, and rarely people can actually pass out. Finally, one condition that can happen when atrial fibrillation is not controlled is if the heart is beating very fast and one is not treated with medications at least, then the bottom chambers can actually start to fail. This is a very important problem. This can result in congestive heart failure. So there are a number of different things that atrial fibrillation can result in. Now, what can we do about atrial fibrillation? As you can see, in terms of stroke, and we're going to deal with that again in just a few minutes, the most important thing that we can do is in those people that are at highest risk for stroke is to give a blood thinner. And the blood thinners can range, and there's a range of possibilities, things such as aspirin to more stronger blood thinners such as warfarin, also called Coumadin, or a newer medication called Pradaxa. First, I want to talk about the symptoms, the various symptoms that one can have. Now, if the symptoms are not terrible, and the symptoms are relatively mild, which can certainly happen, then there may not be a strong reason to try to get one back into regular rhythm. In that kind of a situation, we just use medications that can control the heart rate. That is, we let the heart stay in atrial fibrillation, but we control the heart rate so that it's not beating very quickly. Now, again, that's for people who don't have much in terms of symptoms. For people that do have symptoms, then we have to consider different options, what we call rhythm control, that is trying to keep the heart rhythm back into normal, regular rhythm. In terms of drugs, the short answer is that none of the drugs that we have are perfect. The drugs range in terms of effectiveness, and they range in terms of safety. And as usual, those drugs that are the most effective, unfortunately, also have the worst safety profile. Having said that, depending on one's particular condition, we may be able to use medications that are quite safe and may or may not work. Our treatment in terms of atrial fibrillation is empiric. That means that we try a medication. If it works, that's great. If it doesn't work, then we can sometimes change the dose of the medication. Sometimes we change the medication. And again, the particular medication that's relevant for any single person really depends on the medical condition. Depending on what conditions you have, whether you have heart failure, whether you've had a heart attack, whether you're young and have no medical problems, that will dictate what kind of medications are most appropriate for you. Now, the other major set of options is something called catheter ablation. Now, catheter ablation involves taking catheters, introducing them through the veins and the arteries into the heart, and trying to treat the arrhythmia, trying to get rid of the areas that are causing the fibrillation so that you can stay in regular rhythm. If you look at the figure here on the right, again, it's the top chambers that are causing the fibrillation. And specifically, in most patients, it's the top left chamber called the left atrium, and that's the structure that you see here. Now, rotating on the left side, you see a more realistic three-dimensional image of this top chamber called the left atrium. And what you see as you look at this more accurate image is this tree-like structure. These are veins that drain blood back from the lungs to the heart, also called pulmonary veins. And these are important because it's within these veins that the atrial fibrillation arises. It's within these veins that the problem is and that we have to address. Again, in terms of catheter ablation, as I said, we take catheters, which are long wires that we can manipulate, put them through the veins and the arteries, track them up using an X-ray into the heart, and we perform the procedure. If you look here, this is an image of the left atrium, again, that chamber that's causing the problem, viewed from the back. And you can see the little stars where you have where the origin of the atrial fibrillation arises. And what happens is within these veins, again, the atrial fibrillation initiates and it causes the rest of the heart to fibrillate. What we want to do is to isolate this. And the way we do this is to manipulate the catheter around these veins. So each of these red dots represents a location where you put the catheter, position it at that location, and deliver the energy which basically cauterizes the tissue. So in essence, as we go around the veins in a circular fashion, we want to create a ring of scar tissue so that these electrical impulses which are inside of the veins can't travel out of the veins into the heart, causing fibrillation. In essence, we're sequestering these impulses so that they don't cause the fibrillation. There's different technology that we use, and what I'm showing you here are two examples. The one on the left represents one of the types of mapping systems that we use. These mapping systems allow us to position the catheters within the heart to allow us to understand exactly where the catheter is relative to the anatomy. We actually can obtain an MRI or a CAT scan of one's individual anatomy and use that during the procedure to help us guide the procedure. Now, this is one type of ablation called point-to-point ablation. Again, cauterizing in a point-to-point fashion. On the other side, what you see is a different type of catheter. It's a type of balloon catheter that was recently just approved in the United States called a cryo balloon catheter. This catheter is similar to the other system in the sense that it also is used to ablate tissue. The difference is this catheter is a balloon catheter. The catheter is introduced into the left atrium, it's inflated and pushed up against the vein, and then cryo-refrigerant is delivered to actually freeze the tissue instead of burning it. In essence, whatever approach we use, whether it's the burning that you see on the left or the freezing that you see on the right, the final goal is to isolate the pulmonary veins. In most people with intermittent atrial fibrillation, this is all we need to do. Sometimes the fibrillation comes back, and the reason for this is as you see in this slide. On the left is what we want to do. We want to cauterize the tissue and create a ring of scar tissue. The problem is, imagine locations such as here, where, let's say we ablated the tissue, we caused damage to the tissue, it was not able to electrically conduct, and then we stopped the procedure. But then if we didn't fully damage the tissue at this location, over time it heals, and as it heals, then electrical impulses can then travel through this location and cause the fibrillation again. This is the problem the majority of the time in people with intermittent or paroxysmal atrial fibrillation. The bad news is this requires a second procedure. The good news is the second procedure is typically a pretty easy procedure. It's fairly quick. It involves simply finding usually one or maybe two spots, delivering some energy at those locations, and after that the problem is solved. Now, I should say this is what happens in the majority of patients. In some patients, you may have another location, some random location here or here, for example, and we have to find that location and ablate it. In order to find it, we give high doses of a synthetic form of adrenaline, and that can induce these other arrhythmias, and then we can get rid of these locations also. Now, again, what I've been talking about up to now has mainly been intermittent atrial fibrillation. But many people have what we call persistent atrial fibrillation. In persistent atrial fibrillation or chronic atrial fibrillation, isolation of the pulmonary veins is typically not enough. So yes, first we do ablate around the pulmonary veins, just as you see here. But then we have to do additional ablation. That is, most people don't convert to regular rhythm just after the isolation. Then we have to ablate these other regions. Sometimes we create linear lesions, and sometimes we ablate these other locations. The details are not that critical, but what is important is we oftentimes have to ablate in the body of the left atrium as well as the right atrium, the other top chamber of the heart. And eventually we can get most people into regular rhythm. Now, what's really important and different about ablation of continuous or chronic atrial fibrillation is that unlike paroxysmal or intermittent atrial fibrillation, when we ablate chronic atrial fibrillation, there's a very high incidence of requiring a second procedure. And the reason for that is, as you see here, what can happen is there may be gaps in the ablation lesions that we create, or there may be areas between ablation lesions or pre-existing scars, so you end up with these large circuits called atypical flutter. These flutter circuits are organized rhythms, so in essence it's that last step between the continuum between atrial fibrillation and regular rhythm, these atypical flutters. So that's the good news. The bad news is when these flutters occur, we typically have to do a second procedure. In fact, they occur frequently enough, probably in about half of the patients, that when a patient comes to me with chronic atrial fibrillation, I usually tell them just to expect 2 ablation procedures if we're going to go down this course. What one's individual situation is, it really depends on a lot of factors. Sometimes it's paroxysmal, sometimes it's chronic atrial fibrillation, and the number of ablation procedures, the techniques that we use, really depends on the specifics. Now, catheter ablation, like all procedures, does have some risks. Overall, the risks are not terribly frequent, but there are some risks and you need to know about them. There are 4 unique complications specifically related to catheter ablation of atrial fibrillation that we should address. The first is the risk for stroke. So stroke can happen certainly in patients with atrial fibrillation, but in addition, stroke can happen as a result of catheter ablation. That is, when we're ablating the tissue, because we're damaging the tissue, it's possible for clots to form where we ablate the tissue. And that can, if that happens, then that can travel and cause a stroke. So how do we prevent this? Well, there are a couple of very important points. First, during the procedure, before the procedure, after the procedure, you'll need to stay on a blood thinner. And this may be Coumadin, this may be a medication called Pradaxa, and during the procedure, it's a medication we give through the vein called heparin. That's very important to prevent these clots from forming. In addition, the catheter, the radiofrequency ablation catheter that we use to heat up the tissue, the current generation catheters are such that they're designed so that clot cannot really form on these catheters. They're designed to always stay cool, so that way clot can't form on the catheters and then travel and cause a stroke. The next major complication or potential complication is actually tearing the tissue during ablation. So during ablation, if we heat up the tissue too quickly, that can cause a tear in the tissue and blood can leak out of the heart into the area surrounding the heart. This is something called cardiac tamponade. That's very important because if blood is around the heart, then the heart can't relax. If the heart can't relax, then it can't fill up with blood to push blood around the body. So if that happens, what do we do? Well, the most important thing is to recognize when it's happening. One of the catheters that we use in every one of our procedures is an ultrasound catheter. So this is a catheter that has ultrasound crystals that allow us to look directly at the heart and look directly at the space around the heart to make sure that this fluid is not accumulating. If it does accumulate, then we can deal with it. And the way to deal with it is we numb the tissue just underneath the rib cage, and then we use a catheter to drain blood directly from that space. Again, if we can identify it, we can deal with it, and this typically doesn't result in any long-term problem. Another complication is something called pulmonary vein stenosis. This is particularly a problem earlier in our experience where we often delivered ablation lesions deep inside of these pulmonary veins. Now we use different technology to make sure that we're outside the pulmonary veins. We use the kind of imaging as I described, CT or MR or magnetic resonance imaging, and we also use ultrasound to help us stay outside of the veins. But if pulmonary vein stenosis does occur and it's significant stenosis, then one can require an angioplasty to open up the veins. And the final major complication is something called atrioesophageal fistula. Atrioesophageal fistula is something that occurs very rarely, but when it occurs, it can be quite deadly. What does this mean? Well, the esophagus, the food pipe, as it goes from the mouth to the stomach, it travels behind the heart. Now, and when we're ablating on the back wall of the heart, it is possible and has been described that one can actually damage the esophagus. And one can damage it enough that actually a hole could form between the esophagus and the heart. And this is a big problem. This can result in stroke, in bleeding, and it can even result in mortality. So it's very important to avoid this problem. That's the bad news. The good news is it's very rare. It's a very rare event. And importantly, we have approaches to try to minimize the chance that this can even happen. We can actually measure the temperature in the esophagus to make sure we're not heating up the esophagus. And in certain patients, we can even move the esophagus away from the area of potential damage. These are not all the potential complications that can occur. There are other potential complications that can occur, and we can talk about them in more detail. Now, up to this point, I've been talking about catheter ablation, and we also talked about drugs. There is another option, which is surgical ablation. That is to actually have a surgical procedure to have this catheter, to have the ablation performed under direct vision. This can be done either as an open chest procedure or as a minimally invasive procedure where multiple ports are put between the rib cage. In general, we believe that the surgical ablation procedure is best suited for patients who are also undergoing surgery for something else, say a bypass operation or a valve surgery, etc. Again, in any given patient, it might be appropriate to consider that first, but in general, we like to consider it only at times when one is already undergoing another procedure. As I previously said, the most important complication of atrial fibrillation is stroke. This is the most devastating complication of atrial fibrillation. So no matter what, we have to deal with this potential problem, and there are a couple of different strategies. One of the first questions we have to ask is, how likely is it that you could have a stroke? And there are a number of different factors we have to take into account. That is, there are additional risk factors beyond atrial fibrillation that can put one at higher or lower risk for stroke. For example, if you have high blood pressure, if you have diabetes, if you have heart failure, or if you've had a previous stroke, then you're at particularly high risk for having a recurrent stroke. So, and also over the age of 75. Then as one gets older, the risk of stroke also increases significantly. So we have to look at these particular factors. Based on the overall risk profile, we have a couple of different options. For those that are lowest risk for a stroke, we can treat simply with an aspirin a day. But if you have a higher risk for a stroke, then we have to consider something beyond an aspirin. And there are two major drugs that we can consider. The one that's been around the longest, the one that we have the greatest experience with, is a drug called warfarin, also called Coumadin. This is a drug that you may have heard of. This is a drug that has to be taken every single day, and periodically we have to draw your blood in order to make sure that the level of the Coumadin is adequate. That is, it's not too high, that may cause excessive bleeding, or it's not too low, in which case it wouldn't be protective. Now, there's a newer drug that was recently approved by the FDA in the United States. This drug is called Pradaxa, also called dabigatran. This drug is a little bit different than Coumadin in the sense that it has the advantage that you don't have to do any blood draws. The drug is dosed such that if you just take this particular dose, it'll be effective in the vast majority of people. It also has the advantage over Coumadin that it has less likely chance of causing dangerous bleeding into the brain. The overall chance of bleeding is similar to Coumadin, but again, the risk of bleeding into the brain, the worst kind of bleeding, is lower with this medication, Pradaxa. Now, there are a few downsides to Pradaxa, and we can talk more about them. One of the points is that it is a drug that's taken twice a day, and if you forget to take it, you're not going to be protected. So it's very important to take it twice a day. And the other issue with Pradaxa is that in about a fifth of people, it can cause some gastrointestinal symptoms that can sometimes be bad enough that we have to stop taking the medication. But this is not a dangerous side effect. This is something that's self-limiting, and if we stop taking the medication, the symptoms go away. The only way to know whether or not you'll develop these kind of symptoms is to try the medication and see what happens. Because of the potential for bleeding, some people can't take warfarin or Pradaxa. In that situation, or if for some reason you don't want to take this because of some hardship, there is one other option. the source of the clot in the majority of people with atrial fibrillation is this structure called the left atrial appendage. As you can see in this particular image, this little outpouching of the heart is a blind pouch, again called the left atrial appendage, and when one is in fibrillation, the blood can stagnate in this particular area. And when blood stagnates, clots can form, and when clots form, then they can travel and cause a stroke. So one of the ways to deal with this, instead of giving a blood thinner that affects the whole body, we can try to specifically deal with this left atrial appendage. There are some filter devices that are being worked on around the world, but these are not yet approved in the United States and can only be used as part of a clinical trial. But one other option that we have is something called a lariat device. This particular device allows us to put a suture on the appendage from the outside of the heart. What we do is we numb the skin under the rib cage, and we use a catheter that we introduce to the area around the heart. We pass this loop over this appendage and then scrunch down on this, and as we scrunch down, that ties off the appendage, and then the appendage, this blind pouch, is no longer communicating with the rest of the heart. And you see on these images on the bottom, this is an image and an ultrasound image which shows the whole of the appendage, that is the orifice of the appendage from the inside. This is before ligation, and after we ligate or close the appendage, you can see that this hole no longer exists. This is, again, is an example where we're able to tie off the appendage and effectively deal with the problem. This may or may not be relevant for you, but this is something that the one can certainly discuss.